pavilion at 12:30. Our event is about to start. A quick note, the event will be available in both English and French. If you require simultaneous interpretation, you can grab a headset at the back of the room. L'événement va être disponible en anglais et en français. Si vous voulez utiliser la traduction simultanée, vous pouvez prendre un casque à l'arrière. Sans plus tarder, j'invite William Gagnon à monter sur la scène. Without further ado, I'll invite William Gagnon from the Canadian Coalition for Green Healthcare to come to the stage.
Merci Jacinthe. Je vais inviter mes co-panélistes. Je vais commencer avec Dr Courtney Howard, qui est la présidente de l'Association médicale des territoires du Nord-Ouest, ainsi que co-présidente du Global Climate Health Alliance. Ensuite, on a Lucy Liu, qui est Climate Change Advisor pour le Peter Gilligan Foundation à Toronto. Suivi de Shellyza, who is the co-chair of the Canadian Association of Pharmacy for the Environment. And finally, Vincent Bretin, who is the Climate Program Director at Unité. Merci de vous joindre à nous. Thanks for joining us. It feels very cozy in here because there's not a lot of people, but there's a lot of people online who will watch this afterwards. So I'd like to frame this conversation around why, where, what, how, and who is responsible for decarbonizing our medical supply chains. And I was sick a couple of days ago, and I'm here this morning because I was able to get antibiotics, which makes me no longer contagious, and I'm very grateful that I had access to those antibiotics. But it's not always the case. I've seen personally the delivery of drugs can be impacted when you're a climate refugee or when your hospital is no longer functioning because of a wildfire. So I'd love to start with you, Dr. Courtney Howard. If you could start with the why we need to decarbonize drug supply chains. Can we adapt to climate change? Should we adapt? And how much should we decarbonize our drug supply?
Yeah, thanks, Will. So thanks for coming. And I am an emergency physician in Chief Drug Use Territory in the Northwest Territory. So I serve a patient population, majority Indigenous, that extends all the way up to the high Arctic. Our hospital has the only CT scanner in an area larger than France and Spain combined. So we're warming at triple to quadruple the global rate. One of our hospitals actually sits on permafrost and it's sort of getting unstable. And in 2023, the Canadian wildfires forced the evacuation of our 100-bed hospital because we are not up to date in Canada with regards to the application of our national adaptation strategy. We didn't have an evacuation plan. Our medical director ended up having to figure out how to get a military evacuation plane to come get our patients. They were taken all the way down to Vancouver. And so we lived as evacuees for 3 weeks. The particulate matter air pollution from that event exposed over 354 million people globally to additional levels of air pollution, and it led to over 82,000 global premature deaths. So that's according to a 2025 study in Nature by Zhang et al. And so we're already at a place where we're spending billions of dollars on adaptation. We're already in a place as the president of the Northwest Territories Medical Association. We've spent the whole last year just trying to keep the emergency department open. You can imagine when you evacuate a whole community, 70% of the population of our territory had to evacuate without a plan. You switch from a regular way of functioning to a command and control way of functioning at the drop of a hat. And so people don't really know what their job is. People were recalled from evacuating down the highway with their family to come provide service at the hospital. There was a lot of ruptured relationships. There's a lot of high level of PTSD in the community, which makes it tougher year on year. And that was just 1 year. This last year, again, we had many communities evacuated. So knowing that we're going to continue to warm until about mid-century, we're already having this degree of trouble adapting our healthcare system, even in a high-income country where we have generous creditor in the form of the federal government, which is something that lower income countries that are also first and worst impacted do not have. This is a basically unfillable bucket of money if we continue along the mitigation pathway. And we know that the health sector allocates about 10% of global world product. We have over 40 million trusted messengers across the world. We have previously mobilized them because we have networks that in some cases extend all the way back hundreds of years. The Canadian Medical Association is 150 years old, so those governance structures are actually really good ways to mobilize people. So now that we have 100 countries signed up to sustainable healthcare, that actually gives us purchasing power and political power that I would argue no other sector has. And so in order for us to drive decarbonization via our mass potential impact, we need to lead by example. And we know that many of the emissions are in the drug supply chain, and so that makes this a premier target for us to decarbonize.
Thank you, Courtney. Yes, so global greenhouse gas emissions related to healthcare is 5 to 8% of total greenhouse gas emissions. Aviation is 1.8%, so healthcare is a huge contributor, and also 10% of the global economy. Courtney, you're an emergency physician. Shellyza, you're a pharmacist, so you see patients at different points in their journey. We know that of the 5 to 8% global greenhouse gas emissions, about 70% of those are related to supplies and drugs. So drugs is obviously a big part of greenhouse gas emissions, and mostly in scope 3, so mostly outside of the hospital. How do we decarbonize? What do we decarbonize? Where do we start? How does that work?
Absolutely. So I think it's a really good idea to start with a framework, and I really liked the WHO, low carbon climate resilient framework to start with, and I was really grateful to see such an important emphasis on pharmaceuticals within that wider framework. So to start with, we can think about specific medications, of course, that have a high emissions burden. Will, I know you're doing some excellent work with regards to campaigns to eliminate desflurane, for example, which has such a high emissions burden within hospital institutions. And that is really getting a lot of traction. Another area, of course, is your meter dose inhalers and trying to look at ensuring that meter dose inhalers are used only when clinically appropriate. And there are a lot of opportunities for dry powder inhalers as well. Finally, I would also say that there's a lot of opportunity in terms of reducing drug waste. And the name of the game everywhere now internationally is efficiency. Efficiency. What are the numbers? What are the cost savings? And I feel like in this sector in particular, we have those numbers. We can show how 92% of inhaler doses for MDIs are actually not used. You have for a particular hospital that I won't talk about, but this is a very common thing that happens at multiple hospitals. You get an inhaler that's prescribed. If a patient gets it, the patient goes to another ward, then another inhaler is prescribed. Another area that is really critical, along with measuring unused drug waste, to basically make cases for sustainable capacity, is of course procurement. And I know Vincent will get into a lot more detail with regards to this, but I just wanted to talk about the Canadian context in particular. Sorry. Okay. So in the Canadian context, we're somewhat lucky in Canada. We're both unlucky and lucky at the same time. We're unlucky that we have this separation between, you have the provinces and then you have the federal institutions, of course. And that makes government legislation related to healthcare much more challenging. We are lucky that we have two major group purchasing organizations for hospitals, at least in Canada. And those two group purchasing organizations are starting to incorporate sustainability as part of weighted criteria in their scorecards. What does that mean? That means that suppliers are actually being financially motivated to reduce their emissions. Now, of course, there are barriers. We really need considerations, for example, for transparent, complete, openness on the reporting for LCAs, for example. But at least certain good things are starting to happen. I do think that data also is particularly important, though, with regards to making sure that looking at the various criteria, looking at the life cycle analysis, looking at various criteria within the environmental sustainability landscape, and making sure that we're aligned very well. This is where I think players like Unitate and wider global players can really take a big are already taking a big lead here, and learning from other countries is very important. Lastly, I will just say that we're lucky in Canada. I like to say Canadians are, we have our own challenges, of course, in Canada with various stakeholders, and it's quite challenging with regards to the diversification of interest and trying to make sure that we're aligned. But we have one of the most passionate volunteering bodies that I've ever seen.
Who are you talking about?
In terms of nonprofits, particularly, and just nonprofit capacity is quite good. We've seen this with the Canadian Association of Physicians for the Environment, for example. The Canadian Association of Pharmacy for the Environment is also now liaising with regulatory bodies on climate resilience and emission reduction, liaising with groups like the Canadian Coalition of Green Healthcare, Cascades, and other climate and health organizations, as well as within academia. I do think that this bringing together of stakeholders, particularly with ideas like the Planetary Health Resource Center that Courtney is working towards, is particularly helpful in terms of really getting that alignment, helping with coordination, making the most of our resources, and helping to move forward together. I feel like I've talked a lot, so I will finish.
No, we're actually doing great on time, despite my initial state of mind. So I want to come back to the National Planetary Health Resource Center in a bit. So Lucy, you're in Toronto, and you work with the Peter Gilligan Foundation. The Peter Gilligan Foundation is really aligned. If you read their mission statement, it's all about living healthy lives in a good environment. I'm probably butchering it, but it's the essence of it. PGF has donated a lot of buckets of money to hospitals, especially in Ontario. You guys are funding work that in other countries like the UK and Singapore is funded by government. And I know you don't have much strings attached when you give funding to hospitals, but you do have some power over the fundees. So can you tell me more about your climate work at PGF and how that's received, and how you can bring more climate accountability as part of that?
Yeah, that's an interesting question. I think the story of how climate and health became integrated into our funding priorities is the story, so I'll just start from the beginning. So I work for the Peter Gilligan Foundation, which is a private family foundation that supports initiatives for I'm going to butcher this too, a healthier, more prosperous, and more sustainable future. And we believe we're one of Canada's largest givers to hospitals, especially in Ontario and the GTA. So roughly half of our yearly giving goes to hospitals, and the other half roughly goes towards our grants portfolio, which includes Indigenous youth, international development, children, youth, and families, and of course, climate change. And originally, when the foundation was first put together, it was really focused on hospitals, and the grants portfolio kind of came after. And so it was really clear to the family, it's obviously really clear to society that hospitals are a pillar of our community. But it wasn't until over the last few years that we thought of climate change as being an important aspect to fund. And then we began to understand more about how climate outcomes and health outcomes are actually very interwoven and interdependent. We saw a lot of opportunities in healthcare for decarbonization, which is what we're talking about today. We see a lot of opportunities for climate adaptation, especially disaster mitigation. And then we also see an important opportunity in climate equity, climate justice, and climate resilience. And over the last few years, we kind of brought those values to the table for talking to our hospital partners. So we don't have a perspective of telling our partners exactly what to do. We believe that our partners are the experts, and we listen to them.
but we still share our values, and of course that has power in influencing what they do. Our partners do really great work in sustainability. I think the newest wing that's being built in Mississauga right now has no centralized nitrous oxide system in the plant whatsoever, and it's also built to have sustainability in mind in terms of emissions intensity, embodied carbon, climate resiliency, and of course basic water management. So it's all there. And to my understanding, many, if not all, of our partners have also begun phasing out the use of centralized nitrous oxide, and I believe almost all of our partners have already phased out desflurane. So the values are there, and they're aligning, and of course the great sphere of influence that we can do. Secondly, we also believe that clinicians are a group that needs to be supported, and we love to support them. We support the Canadian Coalition for Green Healthcare in some of this work. And yes, they are very eager people, from what I can tell, and they amaze me every day. But my sense is that they're also overstretched and they're doing a lot of this work on the side of their desk. And even with that, I think it's beautiful because I had a lot of conversation with partners before I came to COP, and what was beautiful was that they didn't talk about that. What they talked about was the support that they wanted, and the support that they wanted was to have more convenings, more spaces to share knowledge, more spaces to share new ideas, because it's practical, of course. It's great to share, like, oh, this worked for me, this might work for you, these are great case studies, you can bring it back to your hospital, et cetera, et cetera. But it was also, I think, a really great way to bring people together and also feel less alone in some of the work that they're doing. And then I think, finally, the last thing I'll just throw in there is that the biggest challenge I hear from all of our partners and all the conversations that I had learning about their work was the lack of dedicated, consistent, long-term, and stable funding. So we, of course, we support this work. We love to support this work, but if there's anyone out there who's interested in building that climate and health focus into their climate change work or their community work, it's there. Like, we definitely invite you to come connect and discuss and talk about how we can amplify our collective impacts that way. So that's absolutely an invitation to other private members like the organization that I work for. But it is also a little bit of a call to action for governments and for maybe even institutional investors, anyone with private funding. I think because ultimately no single source of funding is going to be able to do this huge systems change work that is necessary to make the changes that we want to see. And having multiple sources of funding is really going to create that robust ecosystem of support to make this change over many years and many decades. And I'll just throw this last minute because it's kind of something I've been thinking about a lot. And as I say all this out loud, what we really need to do is we really need to have more people and more leaders and more organizations who really understand and internalize the idea that health solutions can absolutely be climate solutions, and climate solutions can absolutely be health solutions. Thank you.
Thank you, Lucy. Yes, totally. I enjoyed meeting with Peter Dupin last week. He's an accountant by training, but he built more than 100,000 homes. So the guy knows about how to build buildings. But the thing is that most of the emissions are coming from outside of the hospital buildings. And so that's why I think we need to work on the whole ecosystem. So we'll come back to the National Planetary Health Resource Center. But I saw you work at Unité. Unité has done a lot of work on decarbonizing a lot of HIV drugs, both for treatment and prevention. Tell us more about that. I think it's really important to focus on bright spots and case studies of things that have worked, because that generates momentum and gets people excited about the other things we can achieve. So I was pretty excited with your carbon emission reduction with dilated beer, but also letting up your potential to reduce emissions by a ton. So yeah, tell us more about that and the work that Unité does.
Thank you so much, William, and thanks for the invitation. I realize I'm the only non-Canadian on this panel, but it's great to be able to share the experience with you and learn from what you're doing in Canada as well. So Unité is an organization based in Geneva, hosted by WHO, working on introducing health innovations in the global south, to keep it simple. A lot of work in HIV, not just HIV, but our focus on HIV. And over time we realized that we cannot just focus on introducing the products, but that the climate angle is really important for both from a mitigation and adaptation standpoint. 2 years ago, looking at HIV, we published a report called Milligrams to Megatons. We call the report milligrams to megatons because we analyze specific products that are in our portfolio, including HIV treatment. HIV treatment specifically is 650 milligrams of active ingredient in a daily pill taken by a patient. When you look at global emissions of this treatment, reaching more than 20 million people on a daily basis, you reach 2.6 million tons of CO2, so milligrams to megatons, sorry for that. 2.6 million tons. I realize I should have a Canadian analogy for this. I have a Swiss analogy, which is that it's the same emissions as the city of Geneva, to give you a sense, on an annual basis. So that led us to think, okay, this is really serious, and as you mentioned earlier, the health sector and products in particular are responsible for significant emissions. And then we started to look at our history actually, because we supported a lot of work to create this market, to support the introduction of dolutegravir in replacement for the previous HIV treatment. The previous HIV treatment happened to have more API than 650 milligrams, 1.2 grams of API in the daily pill. And when you do the retrospective analysis, you realize that the switch from the previous generation to this HIV treatment has led to the avoidance of 26 million tons of CO2. Something that no one knew at the time, all along during the journey, but retrospectively, obviously, it's very significant. 10 years of emission of the city of Geneva, so going back to Geneva. So that led us to think, okay, there's a strong potential in terms of carbon emission reduction from product switches, and switching to a product is better from a health perspective, but also has less carbon. Lenacapavir is another great example, because a lot of the drivers of emissions are in the API manufacturing. The less API, the less emissions in general. Of course, all APIs are not equal because of the chemistry behind them. When you look at long-acting formulations that are extremely promising for HIV prevention, but also across a range of other diseases, in general, the quantity of API you need in injection for 6 months protection is far less than when you need in the equivalent of 6 monthly treatment based on pills that you swallow every day. And that, for us, is hinting at a very strong potential of not only significant health benefits, but also emission reductions from moving to those types of formulations. But of course, that's not the only part of the story. We also need to look at ways to decarbonize the products that we have. So take dolutegravir. I actually visited, because I wanted to see it for myself, the largest manufacturer of API of dolutegravir. It's a manufacturer based in Visakhapatnam, city in India, that I didn't know about until I came there. And you need to realize the scale of the operations of a generic manufacturer like this one. You get into the site, and you get into an electric car to navigate between the buildings, because you couldn't walk between the buildings. You see fire squads everywhere, tanks of solvents. It's like being on a petroleum place, because there's lots and lots of chemical products in very large quantities that are packed everywhere, going through the process. You get into the building where the DTG is manufactured, and it's a huge building, multiple floors, and you see those reactors that are thousands of liters, all being boiled at 70, 80, 90 degrees, the temperature is super high in the room. And there's 30 such reactors in this company working at any point in time, day and night, to manufacture DTG API. So when you see that for yourself, you realize that actually those operations, you understand where the emissions are coming from. Tons of products, tons of chemicals, tons of energy going into this. Of course, for the outcome that is very important, but a lot of potential to optimize. We work on very price-sensitive markets. You see HIV treatments for countries that have sometimes very few resources. So we are extremely price-sensitive, and we want to make those products as affordable as possible. We will never compromise affordability for low carbon. But during our studies, talking to manufacturers, we engaged with 20 manufacturers over the last few months, getting their data, understanding where they are in decarbonization. We estimate that 30–40% of those emissions could be abated without increasing the cost of production by improving the process, switching some of the raw materials that they use, changing the energy sources, and other optimization measures. So lots of potential, not just from product switches, but also optimization of existing manufacturing.
Wow, thank you. I did not know that. I think it's really interesting to know, like, this. I'd love to visit that factory, because this is just one drug for one disease. And there's like many diseases and many drugs and many people. So it's that's why a lot of the emissions are happening outside of the hospital. Thank you. So where do we go from here? Courtney, you've talked a lot about the National Planetary Health Resource Center. Lucy, you talked about how physicians are overburdened and don't have time to have this myself as well. I also observed that the engineering teams and technical teams in the hospitals don't feel comfortable implementing decarbonization interventions that are clinical because they feel like it's outside of their scope. But the clinical teams don't have time. Like they have a little bit of time, but they don't have time to fully implement. So I think we need to better work as teams to get the clinicians authority and leadership, but to get the time of the technical and engineering team. So Courtney, what would a planetary health resource center look like? What would it do? How would it be funded? And yeah, let's start there.
Yeah, thanks. So we're talking about upskilling our entire set of professions, from students through to practicing docs, and to implement it. So here in Brazil, there's a really interesting concept of a global multi-bow. And so what they're really promoting is everyone at their level doing what they can. And so that means having work bubble up from the bottom, so micro individual level, meso organizational level, city level, macro, subnational, national. But in order to create change, it all has to be aligned. And so I did the landscape assessment for the Association of Faculties of Medicine in Canada last year, which created a roadmap. And what I heard when I was talking to people is that there's so much energy bubbling up, but there's no one to coordinate it, so it's all going in the same direction. And so what we found was that many people were doing the same thing. I must have talked to at least 10 people. We're making a unit on wildfire smoke. We don't need 10 units on wildfire smoke. We need one great one. We need it to be uploaded. We need it to be peer-reviewed. We need it to be available for download, and we need someone to update it probably every 6 months. And then people can download it and tailor it to their context. And then all the other 9 people can do something else. And so right now we have no mechanism. So when we look at the countries where this is working, as you mentioned, they're having government investment. So in the NHS, that's what they have. They have a single employer. They have a central team. They set the policy. They do the data crunching. That their toolkits get sent out to the regions, they get sent out to the individual hospitals. Every single hospital has already had to deliver a net zero plan, and they've written it into their Health and Social Care Act, which sits under the umbrella of their climate change strategy, so they're actually legally accountable. So how do we, in Canada, where we have 14 health systems, achieve that level of what is clearly a rational response? So what we've decided is we need a national secretariat, we need provincial secretariats within each health ministry to organize so that there's that branch of the organizational tree. But because governments come and go, and it takes a long time to convince any one government to take this on as a priority, we decided that probably the safest way for us to make sure we can deliver is to, within the sort of national structures, probably in association with the Association of Faculties of Medicine of Canada, Canadian Medical Association, the colleges, create a secretariat there, so a planetary health resource center that will have functions of practice, policy, and research, so that we can gather, because we've heard from the nurses and we've heard from the pharmacists, they're facing all the same challenges that we are in medicine, but the reality is doctors always have more money and power than the other medical professions. So in this context, we want to make sure that we use that to create the thing, invite everybody else to be part of the thing, do that properly, and get that set up. So we're looking to start sort of a phase 1 where we'll make a pitch to lovely funders like Gilpin Foundation, Trottier Foundation to help us do that convening, set up the governance process, and then move to a phase 2 of getting it started with a phase 3 of having it up and running. And I think we really need to do that in the next sort of 3 years.
Thank you. I also want to talk about having our own pharmacare, our own drug production in Canada as an emission reduction strategy, but also as a resilience strategy. And Shellyza is nodding and smiling at me. We've seen, I think it was Hurricane Maria in Puerto Rico that shut down the IV saline supply chain a couple years ago. Shellyza, tell me more about national drug production.
Yeah, so from a pharmacare perspective, the Canadian Association of Pharmacy for the Environment has been particularly looking at this kind of new advancement of pharmacare. And we've been trying to see, okay, are there potential recommendations for example, the consideration of environmental sustainability first when you're thinking about medications in the context of pharmacare. And then secondly, we did have a lot of experience through the pandemic with drug shortages. And, in response to that, we saw an investment by the Canadian government to look at opportunities to reduce some of these issues by looking at, better coordination, some data that is more available that wasn't as available now, wasn't as available previously, and some incentivizing, for example, on local capacity. But I think that with this new advent of pharmacare, we actually have an additional opportunity to look at further levers with regards to both climate resilience as well as the emission reduction side of things that can actually reduce cost as well. Drug shortages, in addition, are they're so damaging for patient health. They're so damaging from a cost perspective. So really kind of thinking ahead but making smart economic decisions, I think is really, really critical here. And pharmacare is a perfect example of how a resource center of what Courtney was mentioning could be used to really mobilize various stakeholders around the table, including pharmacists, because they know about medications and medication coverage and all of the stuff inside out. To be able to bring people together to then have those individuals available when some of these decisions, continue to be rolled out.
Yeah, thank you so much. So we're phasing out desflurane, we're getting rid of nitrous oxide medicals in hospitals. MDRs, we're talking a lot about heparin, we're talking also about what's the next thing? What's the, I think it's important to focus on success stories to get people excited. What's the next thing?
Procurement. I really feel like I'm really grateful, for example, people like Vincent are on this panel. Although the group purchasing organizations are doing a great job, and we're lucky to have them in terms of incorporating environmental sustainability inside of criteria, we need to be all aligned with regards to having singular messaging around things like, life cycle analysis to be divulged, around things like, how do we detect, the really, really good data. And it's ironic. I heard that this COP is the COP of truth, which is really exciting. And I know that from a truth perspective, we're really thinking about other industries. But from a pharmaceutical company perspective, it would be really great to have specific guidance, for example, on, okay, these are the things you should be thinking about from a life cycle analysis perspective, from a reporting perspective, from a advantages versus disadvantages on plastics, bio-based plastics, all of these various areas. Now I know that Healthcare Without Harm, for example, and Unitated have come up with an excellent supply chain framework, which is coming out soon. But the application of this from a Canadian context, number one, and number two, educating clinicians and pharmacy directors, for example, group purchasing organizations, on how do you really understand the basics with regards to key pillars for supply chain and environmental sustainability. We're lucky to have the group purchasing organizations, but I think that having this data available and all of these stakeholders aligned from a clinician perspective and also from a government perspective would be really helpful here.
Yeah, thank you. I think this kind of like global decarbonization we can't do alone. We must do with other countries. When I was in Singapore, we were working on basically on desflurane, and Baxter, who's a producer of desflurane, invited me to this very prestigious dinner, 5-course meal, rosemary chicken, hello Mr. Gagnon, which is like a parfum voucher, and they flew in this German anesthetist and to tell us why we were not about to ban desflurane. In no uncertain words, but a lot of really complicated climate science that all the anesthetists just glazed over and went back to their meal. And the last slide was, see, this is why we don't have to phase out desflurane. And I was there texting Courtney, and I was like, this is not even worth the free chicken. And pharmaceutical companies are really, really, really powerful. So how do we build alliances between countries? And that question is for you, Vincent. How do we build alliances between countries because Canada could say, oh, we're going to stop purchasing drugs if they're not green or whatever, but we're not going to make a drug in bucket. How do we build those alliances?
No, thank you. Maybe just a quick remark before I get to your question, because you mentioned regional manufacturing or the diversification of manufacturing earlier, and I want to say this is for us also a key priority, also in terms of resilience. You gave a great example, well, not great, but a very striking example of shortage due to something happening at one manufacturing site that the world depends on for one specific product. We work in oxygen manufacturing, for instance, the production of vehicle oxygen, supported by the Canadian government, by the way, in order to improve access to oxygen and reduce reliance on cylinders, transporting oxygen over long distances in African countries, for instance. Back to your question, I think Courtney, you made a very important point at the beginning that in the health sector, you know this very well, there's a lot of public procurement, and procurement tends to be concentrated. And I think that's a strength in terms of decarbonization, because compared to any other sectors where the end consumer decides on procurement, there is actually a very strong public lever to drive decarbonization. In the markets where we work, it's even more true. There's a lot of public funding, even though this is at threat right now because of cuts to aid and development budgets. But a lot of HIV treatments are bought by US government, and bought by Global Fund, and a few countries like South Africa that are large buyers of HIV treatment. So for a market like this, you don't need to put so many people around the table to agree where do we want to go, what's the data telling us, and what's the journey we want to take with the manufacturers to decarbonize, again, without creating any risk of the affordability of the product or the supply security of the product. I know there's been initiatives with NHS and Canada and others to try to align, and everyone recognizes that there is that need to consolidate those procurement signals. Manufacturers are telling us the same, that they don't want one government, one buyer to say, I want you to decarbonize by this much, I want you to report on this form, at those criteria, and then the next buyer asking for different requirements, a different standard for RCA, a different timeline for decarbonization. So that coordination and alignment is going to be super important, because manufacturers will not get on the journey if we don't do it.
Thank you so much. We have about 6 minutes left, and I'd love to give every one of you about a minute and a half some concluding statements. So maybe we'll start with you, Lucy. What gets you excited about where we're going? What do you see coming down there's so much things happening in Canada, so what do you have your eyes on?
Like in climate and health or overall? What I'm excited about is we have only, as a foundation at least, started exploring this idea and trying to bring it back into our foundation, try and share it with leadership, and kind of try and share resources and teach our leadership as well about how important this is. So really what I'm excited about is starting this step and hopefully growing this work and maybe supporting more of this work, and also every time we support something new or we support something different, I get a chance to learn about all of the amazing, crazy things that are going on in the field that have already been going on for much longer than I'd already anticipated. And kind of learning more about the great people that are doing it, the history that's already there, and also the opportunities that are ahead of us. And I'm just excited to be a part of it. I think working for a funder, we don't get a lot of opportunities to dig deep into any topic, but this topic has definitely been something that I'm passionate about. And I'm really excited to learn more and see more and learn more about.
Thank you. That's very nice. Yeah, Shellyza, how about you?
One thing that has been kind of a key reflection point as part of the pharmacy profession is that often we don't really get thought of until people don't have medications on the table, right? And here, it's so exciting for us because medications represent such a big emissions burden. We've been brought in, for example, with the Canadian Coalition of Green Healthcare for feedback-driven resource center. And there's been a lot of really great opportunities for multi-stakeholder alignment, which multi-stakeholder alignment, I think, is the name of the game here. What I would really be interested in is opportunities to continue to sync with our government colleagues on key pillars of climate resilience as well as emission reduction. So climate resilience meaning very, very key, like easy, practical steps on, incorporating pharmacy-related disaster planning inside of adaptation policy. Or on the emission reduction side, having considerations of environmental sustainability even before a medication gets approved, or a medication gets approved for a formulary, for example, for reimbursement. So there's a lot of really exciting opportunities here with regards to coming together and with regards to really growing our capacity in a very coordinated way that can make the most of the limited resources we have. Exciting, of course, about opportunities for increased resources as well.
Thank you. Vincent?
Thanks. Well, I guess what's giving me hope is the increasing readiness and excitement of a wide range of stakeholders around those issues. And if I take the HIV space, the example I provided, it's a very well-developed ecosystem of communities of patients, of NGOs, of country governments that have been involved in the fight against HIV for decades, of industry partners. And I have to say, all of them are increasingly interested and pushing on those issues. When I visited the manufacturer in India, they were actually already doing a number of things to decarbonize their production and really excited about what we could do together to take it further. When we talk to manufacturers in Africa that are just starting to produce, for the same reasons that you outlined earlier, their own medication, their own API, to increase sovereignty, they're interested in doing it in a low carbon way, not just doing it at any cost. When we talk to communities living with HIV, they want a drug that is low carbon. Of course, they want a drug, that's the starting point, but they want a drug that is low carbon and not a drug that contributes to emissions. And country governments likewise are looking more and more at ways that they can decarbonize their health system, and they realize procurement is a very strong way to do it. So I think HIV, and I hope HIV can be a test case in the future of how that community can be brought together to really drive an example of decarbonization.
Merci, Vincent. And finally, Courtney, I'd like to finish with you. And I think we can talk about this publicly now. And I'm not taking any sides because I'm the executive director of the Northwest Territories Medical Association. But you are the sole candidate running to be the president of the Canadian Medical Association. And you founded this year Planetary Health Organizations for Wellbeing, Equity, and Regeneration. So what can we expect coming out of your work in the next year and 2 years?
You don't expect a pointed political question from your roomie. But it makes a morning more fun. So we, through POWER, Planetary Health Organizations for Wellbeing, Equity, and Regeneration, what we're really trying to do is connect the dots in our big country. So we held our first big meeting in October, where we had the Canadian Medical Association president of the Royal College, president of the College of Family Practice, president of the Canadian Nursing Association. We talked about the Canadian Federation of Nursing Unions, had wonderful pharmacists in the room. That's the first time we have ever had all of the leaders in Canada in a room to talk about climate change and health. They all endorsed the idea of this resource center, and you do have the opportunity as the president of the Canadian Medical Association to make sure it gets brought up in every room, and it's a big platform. And so I think I will be able to make sure that it stays on the agenda. It's already part of their strategic plan, so I'm not changing the strategic plan. I'm just making sure it doesn't get lost within their strategic plan. And I think that we're really standing on the cusp of non-linear change. At COP26, I was part of the WHO Civil Society Working Group that set up the COP26 Health Program, which was a sign-on program for climate resilient, sustainable, low-carbon health systems. We went into that COP thinking we'd get maybe 8 or 9 countries signed up. And what happened was the US signed on publicly at the halfway mark, and it drove healthy competition. We left with 52 countries signed up, and now there's 100. So things are slow, the work is slow and grinding until it is not. And we've seen that happen internationally. I think we're at the cusp of that moment in Canada now because all of the faculties of medicine have now signed up. And so it's, I think, incumbent upon us who are leaders in the area to build the structures so that as the doctors and the nurses and the pharmacists come motivated by these wildfires, motivated by supply chain shortages, we can meet them where they are, get them ready for the accreditation criteria that we know is coming. And I think that the real potential of that is it brings the message of healthy people needing a healthy planet into society, which can counter fossil fuel misinformation at the level we need it to change political prioritization. So I think that really it can help the overall drive for a healthy future and long-term well-being for all, and that is what I'm going to try to do with a potential platform as president of the Canadian Medical Association.
Thank you, Courtney. Thank you, Shellyza, first Canadian pharmacist, maybe first pharmacist to attend a COP ever. Thank you, Lucy, for all your leadership inside and outside of PGF on climate. Thank you, Vincent, for your work on decarbonizing HIV drugs and so many other drugs. I think it's like one of the first bright spots that we're looking at. And thanks, Courtney, as well for your work and leadership in Canadian climate and health. Thanks for attending our panel in person and online on decarbonizing medical supply chains. And with that, let's get to work.
Thanks, Will.